We're coming to the end of our journey and time together, and I just want to revisit my opening remarks from the first day and then lead us into segue into next steps here. Where to from here? From my first opening remarks, it follows that risks unacceptable to our nation net patient community include insufficient funding, multiple jurisdictions, and from the patient's experience, how best to access the medical care we need. Funding is needed to cover research and operating costs, as well as ongoing investments to sustain and grow the program to meet increasing demand. The move towards a global conversation holds promise for the much-needed cooperation and collaboration, both nationally and internationally. And for patients, opportunities for an increased understanding of factors to evaluate in choosing among options for the management of advanced net disease and monitoring the outcomes. In addition, and from the patient's perspective and experience, leadership and communication between and amongst the continuum of medical people who manage our care is vital both to quality and extension of life. Each of these will be visited and revisited in different forms during our time together. Said differently, from our perspective, one shared goal is improved outcomes for our net patient community. So given our time together, we now need to move forward from what to so what to now what, and from what is to what might be. Mindful of issues of consistency, continuity, stability, and sustainability across our multiple stakeholders. Here we are at a crucial moment. We need your help. We need your input. We need your direction for consideration. Seldom are issues as simple as either or, rather both and. The wheel of care with spokes and hub needs informed leadership from CNETs and the patients it cares about, from the medical professionals, health system managers, and all working together to form the conceptual glue that holds the wheel together so net patients get the care they need. To do that, we've crafted two questions that we want you to deliberate about. Very important to us are your thoughts. One, what are the most significant aspects of our healthcare system that would help improve the quality of net patient care? And for that, we've given you a worksheet, matrix of issues raised and proposed remedies. Secondly, what actions, specific actions, should CNETs or the medical community health system managers take to address the concerns raised in part one? First, we need to separate so we get the best help possible. Canada, U.S. Who here? U.S. Hands up, please. Okay. Do the other. Who here? Canada. Little more Canada than U.S. Any other? Always mindful of equity. Want to include the other. So, what I'm going to ask you to do then is that we will reorganize ourselves in little comfortable work groups where we grab our chairs, sit together, right, as no more than 6 or 8 in a group, otherwise discussion just gets difficult. U.S. folks, right, so we'll do that. Canadian folks, no more than 6 or 8 in a group. So we're going to have probably, I think there are about 62, 64 people here. Probably we'll have about 10, 12 groups. Ideally, next piece, how many medical professionals do we have in the room? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Great. Looks like 1 per group. So I'm going to invite you to join a group and be part of that. You'll be sort of the resource right there. If any questions need to come your way or as issues come up and need clarification, you have a person there can chat. I've asked Norm and some of the others will be cruising around, any additional medical folks cruising around, so that resources will be around, and any questions that come up, we get a sense of issue in the small group, sense of issue in the large group. Now, within your own group, we'll need a recorder, you pick your own. We'll need a timekeeper, you pick your own. and you pick a spokesperson. And then we're going to have a block of time where the spokesperson shares with us what your group came up with. And we'll ask you to prioritize your items. So we're going to give you 20 minutes to do that. So if we can ask now that you form your groups. Just take your chairs, find some place to work, right? Canadian, if we can ask, be this side of the room. U.S. folks, migrate to that side of the room, form small groups. I'm going to provide the page to the group that's there, right?
I would like to do in the final moments as a medic speaking. This will be the last time now you're going to hear it from the podium, and we're desperately waiting for your thoughts. And this is meant to be an action type of plan, wherein these very strong ideas and suggestions. And I will tell you, I read every one of the comments of the BCC and ETS, the focus questions at the beginning. And one of the things that was brought up at the very beginning by Jim was that this meeting was meant to change. So as you think about what you wrote down in the focus questions and the two questions that you're being asked now, it's very important that you see how this has changed and how you can formulate what we need. And over the next couple of minutes, if I may have that slide, I'm just going to remind you of a schema that you've all heard about, and I'm going through it briefly because I listened to every one of the faculty, and I listened to many of you folks during the breaks and talked to you, and I am convinced that just like bacon and eggs in the morning, chickens contribute and hogs commit. And what I mean by that is that they're all committed people in this room, and the faculty are very committed. And I think what we now need are the contributors to get us to the rim. And on the very top of this little schema, it's a schema that you've heard in different ways all through the last 2 days. And you are the hub, as we heard from Dr. Warner, and the spokes are the boxes on that sheet. There's no new boxes that you haven't seen. There's the Octrea scan box. There's the somatostatin, lanreotide, sandostatin box. There's the surgery box, sophisticated surgery box. Now we have it where they can put a probe in and spend extra hours and do the minutiae dissection. You can laser lesions from the liver. You heard from the best committed people how that's done. You heard about hepatic arterial embolization. You heard about bland embolization. You heard about sophisticated Y90. And from our European colleagues, they're now infusing the same systemic therapy that they give patients called PRRT. You've heard it that they can even give that into the liver safely. So that's the hepatic arterial embolization box. You've heard the box of PRRT. Very well. We've heard it, and now Canada has announced the possibilities very near rather than far of having PRRT in your own country. We also heard that when those receptors aren't there and the tumor misbehaves and becomes more progressive over time, perhaps, over the years of longevity, that now we have a very rational, as Dr. Wolin pointed up, reason to give chemotherapy. And we also heard about the novel anti-angiogenic therapies. Every one of those boxes, and if I sound preachy, I apologize, but every one of those boxes are good options. But a good option at the wrong time ain't your best option. And what you're asking now, or what we're asking you to help us with, is to connect that rim. Because the rim people have a part of the connection for the circle, and they're the ones that help guide which spokes you need. And I share that too as another thought. You know, early on, carcinoid tumors were called by the medical oncologist cancer in slow motion. I prefer, because of my own chronic problem, to call it the diabetes of cancer. And 10 years ago, I must tell you, when I was 58 years old and I walked in with a little shortness of breath and my colleague said, well, let's draw some blood. I think you're having a heart attack. And at the end of the day, he said, your sugar's high, your lipids are high, your blood pressure is high, and oh yes, you've had a heart attack and need 5 vessels. He paused and then he said to me, but your prostate-specific antigen is normal. Well, I was so excited when I heard that, I went out and had dinner and then came back to the hospital and was admitted and had 5 vessels the next day. So it's what you hear and how you respond to it. In my way of thinking, I think it's like acute traumatic stress. And I'm not so sure that some of us and all of us don't suffer chronic traumatic stress when you hear that kind of thing, such as cancer, or in a lot of my practice, when you tell somebody you have diabetes, it's like the curse. And it leaves you with all kinds of funny feelings in your head. So I know that other side of living with a chronic problem, but that's the point. It is chronic. And as long as you keep doing the options appropriately, you keep turning that clock back. And we heard numbers like 15, 20, and 25 years of quality of life prognosis. And that's what you all need to hear. And so, we've seen it. You've seen the spokes from the committed people. And now I think the time has come for you to give back. I mean it in spades, in very focused, very delineated how-to. How do you get to the rim, as Jim Cormo says? How do we help you? How do we get to the rim for you or get you to the rim? We've heard great things, and this is what we need now from you. Very focused comments. Because you've all had the pain. I've read your pain, and I know your pain. I could fill one of these out just like all of you did. So this is the time now, and I'm going to stop, and I'm going to walk around, and if I can answer any questions from my spoke, I'll be happy to do it. One thing I think is very clear, though, to get to the rim, you've got to have a person that's an orchestrator of some sort. Centers of excellence have been bandied around all for the last 2 days. Centers of excellence are going to be very competitive. What you need is a person who says expressed interest in. And if you go to the United States right now, you have one of your spoke leaders being medical oncologists, or many. You have spoke leaders being endocrinologists, a few. And you have spoke leaders being surgeons and gastroenterologists that make up the kind of the leadership. But the most important thing about any of those people with an interest in neuroendocrine tumors is that they can help guide your decision. And you need to tell us how we can best. I think the guidelines are one start for family medicine. Because in the United States, they read those guidelines. They read them from cover to cover. After that, I'm not so sure the specialists really do read. So how to get at those groups, the physicians that express an interest in the field. One last thought I thought was very interesting that I heard a week ago about the healthcare, the cost of healthcare in the United States. What they said is, the first sentence was, the cost of cancer has doubled. And then the next sentence says, however, the total percent of cancer cost makes up only 5% of the total healthcare budget. I promise you, that will never, the cancers such as your cancer in slow motion, your diabetes of cancer, your chronic problem will not be cut out of any budget, anytime, probably from any country. It's impossible. I'm stopping. Thank you very much.
So we have 3 tables and 4 tables Canadian. So when the spokesperson, the reporter, comes up from your table to the microphone, could you please give your name and country? That way we know when we look at this and listen to this later that we're listening to responses through the filter of the U.S. patient experience, needs, and wants. Same way for Canadian. That way we'll be able to keep track. Reporter number 1, please, a volunteer, okay? Which table? Thanks, Josh. You have a microphone there. They're handheld mics, I think, so.
I'm Josh Mailman. I am from the U.S. I represent that wonderful table over there. So we discussed several things. Actually, we ended up only answering pretty much the first question. The second question, we just said you should advocate for awareness. But let me go through and kind of give you what I thought. Most significant aspects of healthcare that would improve the quality of NET patient care. So the first thing we came up with was having a NET guideline for our NETs doctors that as part of the gastro guidelines, NET should be in there that gives them specific ways to look for NET if they have patients that are falling through the cracks on other sides. We also thought it should be part of their boards. Secondly, many of us have problems getting our medical records or pulling teeth getting medical records. So we actually believe that there should be more availability of EMR, and the EMR should be used for our own goods to get our records so that we can pass them to physicians, and that also a system should be set up to de-identify data for NET patients that could be made available to centers of excellence to look at the specific markers and to share information to see if we fit into, instead of us going to search out centers of excellence for care, that centers of excellence would be able to look at de-identified data and see if we fit any of their criteria for care so that they can actually be contacting us. Thirdly, we look at, in the U.S. again, since this was a U.S. table, when we get diagnosed, there is not really a center of areas to go to look at for information. Many people went to different places, whether it's the American Cancer Society or one went to PanCan and got immediately freaked out. Different parts. There needs to be a centered place where a patient who just got newly diagnosed can go and be sure they're getting the guidelines. It should be easier to find. I don't think the first place that everyone who has an NET or a carcinoid goes is pancreas.org. So it needs to be somewhere that people routinely go to when they look for a cancer diagnosis. Along that line, people who diagnose for or who are specialists in NETs should be able to have the guidelines and to hand them to their patients when they're being seen on diagnosis so they don't have to search. We had many people at the table who have been diagnosed for decades and have no idea what the guidelines or do not have a full set of guidelines and don't even feel that today they would have all the information that was listed in Dr. Odericio's slide, even 10 years after diagnosis. And lastly, there was one concern that when there are other clinical trials that are done outside of North America, adding our Canadian brethren here, that information be helpful or be used to fast track or speed up acceptance of a drug or treatment in North America instead of having to rethink and redo the trials. So that was our kind of 4 major points.
Okay. My name's Kathy Arbanison. I'm from Central California, and I'm representing Table 2 here. And most of us actually are from, well, I don't know. I guess we are from different parts of the United States. So anyway, we basically just addressed question 1 because there wasn't like a lot of time. And we did have a doctor at the table, and well, he was trying to like promote, well, what he thought at first, and that took up a little of our time. But anyway, what we did say was that education is key. Again, we need more awareness and stuff. And also, when people get diagnosed, it seems that to find the right doctors, we need to find a place where we can readily find a list of doctors to choose from that comes up on the web, like as a first hit. And we mentioned that we have the Carcinoid Cancer Foundation list of experts, but, you find that by going to the Carcinoid Cancer Foundation first and then finding the list, but it would be really nice if there was like a website that just gave us like a list of experts, and not only as it's currently constructed, but what these experts actually do, like, what their specific little subspecialties are, because another question came up that, like, even though you have this list of experts, how do you know that this is the kind of expert that you need that's going to help you with a specific type of neuroendocrine tumor that you have? And then there's it's like, as Dr. Odorizio was saying, finding the right spoke. He was trying to say that, like, he thinks the oncologist is going to be central to our care, and that's who's going to drive us there. But there were a number of lung carcinoid patients here in our table, and with the lung carcinoid patients, it's kind of like we're seldom sent to an oncologist when we're first diagnosed. We're sent to a lung surgeon and maybe a pulmonologist, and then they tell us that we don't need an oncologist because maybe after our surgery we will be cured. So we have to get to the oncologist first, if that's the person who is going to be important to our care. Let's see. Then once we find a doctor, then the issue comes up of how do we approach the doctor. Once we find the doctor and find all the information, we do our research on our own and go to these conferences. How do we convey this information to the doctor in our local level without offending the doctor? And how do we get the doctor to listen to us is another problem we have to address. Let's see. Okay, then there's the other obstacle that we face in our country, and that's the different types of medical care plans that we're under, and the different types of situations that we all live in, that there are many restrictions on where we can go for medical care, and that these are, ruled by what means we have. Some people are on Medicaid and they're restricted by that, and that goes to the bigger problem of, like, how does our insurance restrict us and where we can go, and then how does our location restrict us where we can go, because even if we don't have such restrictions, maybe some people are too sick to travel or something like that, and they really need to find medical care in their area. And what if they live out in the boondocks and there's nobody who really knows about carcinoid where they live? And let's see. So then, this is sort of like borderline between 1 and 2. We really didn't get to question number 2, but it was like somebody mentioned that it would be really nice to have like some kind of group that would coordinate like all of the advocacy and information or whatever efforts and everything, one big international group. Yes, we had that sort of with NAPNet. Okay, great. Okay, that's and I guess, yeah, we did talk about that sort of last year, but yes. So I guess that goes to World Cancer Awareness Day. So, okay. Anyway, that's all we had time for.
Well, we got many of the same sort of issues that other people have already highlighted. Some of the things we found was, how do you go about organizing your team? How do you gather more information? How do you actually get better at transporting that benchmark information? I think Josh had a very good idea about EMR and things like that. Actually, transport and collection of information. My wife, when she had to go and do a presentation to another set of doctors, spent about a month actually collecting all the information. And then what I think most of the experts have been talking about here is better diagnostic guidelines. One of the things that we spent a lot of time talking about was increasing the awareness at the medical school, and making sure that it's actually included as part of the curriculum, making more awareness of the disease itself. Is there a difference in the U.S. between it and socialized medicine and how NETs are going to be approached, or should there be a more general global approach that is also U.S. inclusive? How do you go about finding an expert? One of our people brought up the Wellness Day, how to highlight our plight. I thought the idea of having it go to newspapers or other mechanisms, there might be cancer support societies and things like that. Define each person individually, because this is a very individual disease. Linking centers of excellence. Grading patients and conditions. One of the things that one of the other people brought to our table is patient handouts. There's probably needs to be a standard handout generated. And then like a carcinoid passport, in other words, it's identification where you'd be most having your case history and stuff like that. It could either be electronic or paper to be able to carry with you. And then I think everybody here has been talking about the global conference on updating things and stuff like that. Okay?
My name's Lily Lee. I'm a physician here, medical oncologist, and I'm representing this table of lovely women. And what's become most apparent is the frustration in educating their caregivers. So they wish to increase education at the medical school level, education of their family doctors, and also in terms of their specialists, and especially the oncologists, perhaps to have more oncologists or fewer oncologists specialize in looking after NET patients so that they increase the volume of patients that they're seeing and increase their expertise as a means of improving their care. And then education of themselves, so they'd like a means of accessing guidelines and information, and networks like CNET is a way to start that, and that's a relatively new network, but to connect to perhaps the Canadian Cancer Society and other organizations that provide patient information so that you have links to get to your site. And then perhaps creating a registry of doctors with an interest in looking after patients with NET. Again, that list has to be somewhere very accessible so that, say you're newly diagnosed with your NET, you can be given a place to go. And then help with navigating the system. Because as you've heard, if you have certain types of carcinoid, you don't even get to see an oncologist. And if the oncologist is thought to be the hub, then perhaps there needs to be a standardization when it comes to that. The lung carcinoid patients are asking for Canadian guidelines and perhaps other non-GI NETs. And I think that was our list for question number 1.
Hi, my name is Kong Koo. I'm a medical oncologist also at the BC Cancer Agency. I'm also involved with advocacy through the Cancer Advocacy Coalition. Anyway, our table reiterated a lot of the discussions already had. Primary problem we identified was the lack of awareness about this disease at multiple levels, within patient groups, within the medical community, and even within subspecialists within the medical community. And this would have to be tackled at multiple levels. Things that reach out to the general public, to the medical profession, to professional specialty societies. And there's going to have to be a multi-pronged approach. Another barrier was all the access to all this exciting radionuclide imaging tests and specialized treatments. And in Canada, we have a lot of disparity amongst the provinces about what is funded and where you can get these treatments. And that can certainly be organized, and it's the responsibility of our healthcare system to do so. However, this probably answers this question too. That's not going to happen without some key political advocacy. And we talked about how we need to have this awareness out in the media. I don't see any media people here. And unless your message gets out to a broader constituency, you're not going to get that support. And the politicians won't hear it. We also, in terms of barriers, need to get other organizations like Health Canada, especially for radionuclides, which is a very unique area. We've had many issues over the years trying to get these treatments in Canada, and I think the time is right now to do so. I'm sure Sandy McEwen will agree. Third area we thought of with this, it probably had to do with this issue of access and the complexity and the fact that there's so many areas of expertise. And I myself work in a small center, and I'm the only oncologist, for the most part, seeing the vast majority of these treatments, but I don't have that area of expertise. And I think you can do it without a center of expertise, but you need the networks, you need the other collaborators. And I think in this time, in this area of technology, there was mention about electronic health record, why that can't follow you to England or Uppsala or wherever. And I think that capability is real, it exists, and it should be further developed. But patients are confused. They don't know who to go to. There's no one resource. And there's a need for navigators or coordinators. Maybe that might be a nurse practitioner at a larger center, as we heard from a speaker yesterday. But we need it for these smaller communities. And the gatekeepers are probably going to be physicians. So that needs to be coordinated. And I guess probably the fourth and final one had to do with lung carcinoid. That seems to be an orphan tumor within an orphan tumor group. And attention needs to be placed on research in that area and highlighting their specific issues. Because the way their care gets provided through a different set of people and systems in place. So you need to address those components.
It's hard to go last because everybody's already said most of the things. I'm Dave Fiddler. I'm from Ontario. One of the comments that we had was that they should be adopting the guideline. We should encourage adoption of the guidelines across the country. In other words, you have your guidelines, and now it's up to us to try to get the guidelines around the country to be adopted and accepted. And it's the government's jobs to basically honor those guidelines that are met. And so that's one of the things that we're talking about. Getting a standard. You have a standard, you need to make sure that the governments honor those standards. There's lots of talk about center of excellence. And Canada's a big country, and unlike the United States, where you guys have lots of big cities and everybody's pretty close to things, there's a lot of people in Canada that don't really have access the same to care as we might have in the United States to get even close. I mean, and also there's different socioeconomic things. I looked around at our table, there's 2 physicians that have the disease, and 1 patient's husband's a physician who has the disease. That means there's lots of other people around here that really can't afford to be at these kind of meetings. They can't afford to travel from Newfoundland to Edmonton to get their treatments and stuff down the road. So we need to make sure that we try to get something that's geographically reasonable across the country for people to get to. And with our telemedicine and all those kind of things, I think there's opportunities for those things to have centers of excellence somehow linked. And maybe it won't cost you as much for your center of excellences, but if you can link them to the experts from a distance, and that would help a lot of other people that really can't afford it. So including you should be able to have diagnostic testing like our triatad scan should be available to people, not just to have to fly all the way from Halifax, or I think Halifax has it, but to go long distances. We talked about training of doctors, and I think that's been enunciated by a number of people, getting people more aware of what the problems are. And we need to make sure that we have standard follow-up and testing available to all. In other words, I don't see a standard follow-up test right across the province, right across the country that we're all using and how we're following people. We get the test done, and then we're sort of let this person follows us this way and that person follows us that way, and I don't see, we see about chromogranin A's, and in Canada we can't get polypeptide P's and we can't get neurokinin, so we just don't do it because we can't afford it. We need to advocate for the things that are current and up to date and not just go on an expense basis only. As far as question number 2, what specific actions should CNETs and the medical community? I have to be honest with you, I think this was an excellent conference, and I see that CNETs is doing a good job. And I really don't have a lot to add to you, except I think you're gaining more information of where to go, and I think this has been wonderful. Thank you.
I think I'm the last one. I'm Suzanne Campbell. I'm actually a rural family physician from British Columbia as well, though my partner is hopefully nearing the end of a 2-year web of pre-diagnosis and diagnosis. So just off the start, one of the things I want to mention, as much as you educate, obviously I educated myself a lot in this process, there's still a lot of problems with diagnosis, and our multidisciplinary centers need to address that as well, not just once you have a diagnosis, but where can you send someone when you know they may have this, to expedite tests and have them done properly. So things that came up at our table, which have already been mentioned, but I will reiterate, is education. And not only of the family physicians, but as well, one of the people at our table has had multiple emergency visits. And that sort of connection, the education of the emergency physicians, as well as when they do sort of think of a carcinoid, who do I send these people to? So someone else mentioned having a list of experts in the area, and I think that's great. I honestly don't know whether you have that on your website or not. That would be wonderful, yeah, because as you know, Dr. DeHerter mentioned, if the annual endocrinology conference has one talk on this, if that's what the endocrinologists are getting, you know, you need to go to the endocrinologists that are doing more than one talk a year on it. So that would be wonderful. Education of medical students, and as well it was brought up to make sure that the information is correct. There's still a lot of sort of sense out there that carcinoid is a benign tumor and therefore doesn't require any urgency. And obviously that's incorrect. Something else that came up is just, and I'm not sure how CNETs can address this, but I think, again, having a multidisciplinary center would help, is having the test done appropriately. So if you're sent to the lab for a certain test, but you didn't get the instructions of how to prepare, or if you're sent for a CT scan, but it wasn't a multi-phase of your liver, and therefore you have to go back and get it done a month later, and the cost is double or triple, that sounds like it's actually something that happens quite commonly. And so once someone has figured out what you need, to make sure that it's done correctly the first time. And so number two, what specific actions can CNETs and the medical community and health system managers focus on? And basically, we sort of felt advocating for a multidisciplinary center. And as the speaker before me mentioned, or the person before me mentioned, obviously people from Newfoundland, it's not going to be easy for them to get to London or Calgary. But if you have the hub, then you can connect the spokes. You know, so at least if you have a place where you can get the diagnosis or the pre-diagnosis and get a treatment plan, then you can go back to your community and receive the treatment. Or I think it was a very good idea, electronic medicine, teleconferencing. We do that a lot in rural communities in British Columbia, and being able to then link that in. You may not need to go to Calgary, but at least you can connect to Calgary. And then I think it would be really helpful to have a list of people who are sort of experts in the field, so that your endocrinologist, if they're not, they can find out who to send you to, or your gastroenterologist or your family physician. Or if you're just looking for a second opinion, you know who to ask to go and see.
Excellent, thank you. So we've gone the rounds for question one with our U.S. friends and our Canadian colleagues here. And we've started to come back the other way now with response to question number two, except for this group, right? So could we hear question number two now from our Canadian group? And then I think, did everybody respond to question two over here? Okay, so we'll move over to the U.S. group after this.
Okay, so with regards to specific actions that should be taken by these various organizations. So with regards to CNETs, there's a request that when the guidelines, well, perhaps the current guidelines can be posted, and then when the update is published in June, for it to then be linked to your website. And then we know that the presentations from this meeting are going to be uploaded at some point, as much as possible. A list of experts to be generated and maintained and updated. To continue with organizing your advocacy and your meetings as you've been doing, because you've done a fantastic job at that. And to help disperse information, so whether to organize for education, means of education, so whether to have speakers travel, or even to make the guidelines available to medical professionals through their societies or whatnot. That's a suggestion. Amongst the specialists and members of the medical community, better communication is required. We're all very busy, and granted, we do ignore half our mail and much of our email and whatnot, but that needs to be improved. And then with regards to health system manager, so this refers to Health Canada and the provinces. So support of at least Edmonton's initiatives to get the radionucleotide treatment going would be very greatly appreciated from Health Canada's point of view, and then among the provinces to recognize that funding for treatment in centers like Edmonton is needed, and for that to be allowed so that patients can travel and not have to worry about not only the cost of the treatment but the cost of the travel. It is a relatively small number of patients that is affected by this, and so that's something to be considered.
Okay, yeah, we had people pass down things. I guess somebody said that we can give oncologists books from these conferences and things like this to help make them more aware, and and make them aware of carcinoid support groups to let their patients know where they can go to find other patients to learn more information. And I guess I had some ideas from what was said here, too. I like the idea of electronic medical records in one sense to be able to access them more and everything. But the issue of privacy comes along with that, too. And that's something to be considered. Right now in the U.S. we do have HIPAA laws. They exist. And our medical records should be pretty straightforward to obtain, but often they're not. And this brings the whole issue in the U.S. of the enforcement of our healthcare laws. How good is that and everything? And it also goes into the issue of how do you communicate with your doctor to not offend him, and what do you do about it if you are limited in your medical care choices, and then all of a sudden you can't get the care you need, although you might have some ideas as to where to send doctors for such care and everything, or to consult on them and everything. And we need to kind of advocate for each other and find resources where you can call a lot of these support agencies. Maybe they'll help you with little insurance issues and stuff, but there aren't people out there who will really help people be a link between patients and doctors to help come with a better simple understanding through I guess amicable means and everything to mediate between them to make a win-win situation for all. And we need to come up with some kind of system for that, I think. Okay.
I didn't identify myself last time. I'm Ken Latoza from Redmond in the U.S. That's Washington. I think one of the things that I have heard underlying this is how do we actually go about improving the medical education process. There's several things. One is that we can always sort of lobby to make sure that the medical schools actually do teach and include that. But I think we could probably go farther if we either offer up fellowship ideas, in other words, endow some kind of either fellowship program or some other teaching mechanisms to make sure that the discipline is actually taught. And that can also sort of act as a foci for the centers of excellence. I mean, if most of the people who learned here about chronic carcinoid sort of diseases learned it in certain places around one certain person, and we want to make sure that those centers stay alive and grow over time so the information can be further distributed throughout the medical community. I think the other good idea is patient handouts should be produced. I mean, we can either model the one after ones that have already been produced in Europe, or we can actually go and produce new ones based on more modular or newer guidelines. I think these guidelines could be, I should say, these handouts can be generated from either the guidelines in some kind of watered down form, or it could actually be generated anew. And then finally, I think the concept of having a centralized website where all the information can be found, in other words, some carcinoid.org that's over the whole world in multiple languages and things like that, because we know there's language barriers, both for dissemination of information, but also as collection. In other words, they should be able to post diagnostic sets of data up there in a pre-subscribed format, and either have them stored or analyzed for other people. One of the big problems that you're always going to have is, because this is going to be a small population disease, at least we hope so, that you're going to have difficulty collecting information, and the more information you can collect is going to be good over time. Thank you.
Well, a lot of information. Thank you, everybody, for your thought and your care in putting together what you feel from experience and observation and understanding consider as most important for CNETS Canada to take away from this as we work with our multi-modality partners, our team with Health Canada and our pharmaceutical friends to see how we might best work in a strategic, informed way to get the best access to the best care for all of our net patient community across Canada. So thank you for that, and over to our President, Marie.
We would very much like your help. We would like to work with anyone in this group who would like to work with us, because the more that we can do, the better it can be for us. And we need your thoughts, your insights, and your actions. We need your every day, your energy. We need your energy very much. So please email me at maureenc@simpatico.ca if you would like to be part of this organization in any way at all, and we will move forward together. Thank you so much. And before I'm going to stop now because it's the part is that. Thank you so much, and please stay in touch. And I'd like to talk to our BC oncologists who are here as well before you go, because I haven't had a chance. I can say hello to lots of people. I haven't really had a chance. Sorry, I haven't had a chance to say hello properly to many people, and would love to talk more. Don't forget to sign that World Proclamation. So this is going to go on the New World website. But please connect with me if you would like to help in any way with CNETS Canada, and maureenc@simpatico.ca. Jim is Jim Corpus at Rogers.com, and we will enlarge our circle and it will help us move forward, not just for Canada but for the world. Thank you.
Just if everybody could just stay in their seats for a little longer, and I would like to ask Maureen and Jim to come up here, please. And I just want to say, on behalf of everybody here, perhaps do I need to be here? On behalf of everybody who's taken part in this conference, whether you were a medic on the medical side, or the caregiver, or the patient side, I think we've all benefited tremendously. And these two and CNETS have spent months and months. I can't imagine how much time they spent getting all this together. So on behalf of everybody, I want to thank you. Thank you, Marcia. So much. I don't know what we would have done without them. And I understand that Jim likes coffee, so he can go to his favorite roll up the brim shop and get his cup.
Oh, thank you.
Now, Marcia, you stand there for a minute.
Oh, no.
Stay there. Marcia, you have coordinated all the volunteers at this conference.
Thank you.
We both. And it's so nice that we both have flowers.
You know what? She walked by earlier and she saw the flowers and she said, "What's this?" And I said, "Just carry on."
But you didn't see the other ones?
I didn't see them. Oh, bless your heart. Thank you.
I thought you had them already because I've been out of the room.
Thank you. Thank you for doing a wonderful job for all of us.
Thank you.
Well, as we say goodbye, we hope that you have found your experience and your time together here with us and with each other personally meaningful and practically relevant, and that we wish you and hope for you a safe journey home if you're staying in BC for a little while, to savor and enjoy the environment. Please do that, but take good care of yourself. Till next time, bye.